I'm just going to give you a perspective of me as a spinal surgeon. When I look at images, what do I look at? What am I looking in the report? But more importantly, sometimes in the UAE is actually what the insurance company actually wants to see as well, for us to be able to treat the patients. So just a little bit about myself. I'm a spinal surgeon. I'm an orthopedic trained spinal surgeon, so I'm not a neurosurgeon. I specialize in scoliosis, both pediatric and adults, and complex spine surgery. I used to work in a quaternary center in the UK, and for those who know what this jersey actually is which team for, you would know that I used to work in Stoke-on-Trent, which is quite a big hospital, and this is the scoliosis team and the spinal surgery team over there. And most of the radiology I learned, and I sort of picked up quite a lot. I didn't learn radiology, I didn't train in radiology, but we used to have a Friday MDT, which usually lasted for about 4 or 5 hours, and we had 3 MSK radiologists discussing all the complex cases. So over time, you learn quite a lot from these guys. So I'm not here to give you a talk about how to give reports or what things, the different grading systems for various different things, stenosis or degeneration or anything else. I'm just here to tell you how I look at the images and how I treat patients. Probably give you a little bit more information about conditions that not all of you have seen before either. I don't do any intradural tumors or brain tumors, so I will spare you the hassle of that. And excuse me if I manage to report certain things as per what I see them, but they may not always align with how you've been trained or taught. But I will tell you the reason I tend to do them. So the reason we're doing it is so that you can get a perspective of how we look at X-rays and MRI scans and CTs for that reason. It is important for you to help us, because at the end of the day, nowadays, if I write something or I write a report and I write what my opinion on an image is, the insurance company doesn't really care what I think. It's more important what's on the report. So if something has been underreported, then it creates a bit of problem. And similarly, if it's been overreported, it also creates a little bit of a problem. So in general, what I'm saying is, even if it's not there, try and mention it on the report if they need it. And we'll talk about that in a minute. So I'm not going to talk to you about degenerative lumbar spine. I'm not going to say about, disc disease or stenosis or, a little bit of foraminal narrowing and some modic changes. That's not what I'm not going to train people, or this is not what the problem is. The problem comes when we have complex stuff such as scoliosis or patients who have metal work in their spine already. That's when the reports become a little bit less specific. So to start with, I'm just going to give you a background on some of the conditions that I look at and I treat, in the hope that, when you come to report on these patients, the background of these conditions and the slight differences and what I am looking for on these specific X-rays or specific scans. Scoliosis is one of the things I deal with a lot. This is what I trained in. And in principle, scoliosis is a lateral curvature of the spine, and this is based on the Scoliosis Research Society definition, which is more than 10 degrees. So anything less than 10 degrees, just don't call it scoliosis. Just call it a curvature of the spine, or which is within normal limits. Clearly, that hugely depends on the age of the child, depends on how the X-ray is being performed, and whether it's a standing X-ray or a supine X-ray, which matters hugely. I wouldn't want people to put cob angles on supine X-rays. It's not. I would just say there's a significant curvature of the spine. We would recommend a standing X-ray, because we should not be measuring curves or kyphosis or any deformities of the spine on a supine film. It's a 3D deformity. Okay, so in other words, there's a coronal change, there's a sagittal change, but also there's a transverse plane change as well. So there's a rotation. And this is probably why we have a situation where there's a little bit of issue with people calling this a kyphoscoliosis quite often. So even most scoliosis is not kyphoscoliosis. Most of it actually is lordoscoliosis, which is well illustrated in the last picture on the right. And the reason they're called a kyphoscoliosis usually is because of the prominent rib hump. But the spine itself is actually not kyphotic. It's actually lordotic, if anything. The different types of scoliosis include early onset, congenital, and the secondary scoliosis, such as neuromuscular, syndromic, or traumatic, and then the late onset, and then the adult ones. The biggest distinction really is between early and late. Early onset scoliosis is scoliosis that starts before the age of 10, and late onset is in adolescence. And then you've got the adult, which is usually beyond skeletal maturity. And we'll just talk about these slowly, over the next few slides. Early onset scoliosis before the age of 10, but to be honest, most of it and the most important ones are the ones that actually start at the age of 3 or 4, or ideally, or not ideally, or before the age of 7. And the reason I put that distinction of 7 or 8 years is because of the alveolar maturation. So at the age of 8, children develop their full alveolar maturation, or at least 90% of what the adult alveoli numbers are. And therefore, if you have a scoliosis after that age group, although it can become severe and result in a cosmetic problem, it doesn't really result in a significant respiratory issue, or certainly not as significant as if it started at the age of 3, when it can actually cause a significant restrictive lung problem and cardiac problems in the future. So there's a slight distinction between very early, or what we used to call in the past infantile, and what is about 7 or 8 years of age, which is juvenile. Okay, those that start after the age of 10 are adolescent. Early onset scoliosis mostly happen in young boys. Usually it's a left-sided curve, as you can see on the image on the right, although this one is in a girl. We need to make sure this is idiopathic or is of unknown cause, because early onset scoliosis can also affect children with various different congenital anomalies, syndromes, neuromuscular problems, so on and so forth. So there's various things we can look at to check whether this on the X-ray is idiopathic or not. So if you see fused ribs, then the chances are the child has a block vertebra or something that we need to check on an MRI scan or a CT scan. Congenital anomalies are usually quite evident, like a hemivertebra. The child may have evidence of spina bifida, a sprangled shoulder, or the hips might be abnormal or dislocated in neuromuscular kids. That thing at the bottom you see, the RVAD, is the rib vertebral angle difference and the rib phase. These things are things that we look at on the X-ray. These things were described by Min Mehta in Great Ormond Street in London. And they have actually revolutionized the management of early onset scoliosis. And principally what you look on the X-ray is at the apex of the curve. You need to find the apex of the curve in a child who presents with a scoliosis at the age of 4 or 5. And what you see is at the apex of the curve, if the convex rib is overlapping the vertebral body, then we call that phase 2. And that's at presentation. And if you've got a phase 2 curve, then the chances of progression are high. Okay. Similarly, there's the rib vertebral angle difference, which again you can measure on X-ray. Okay. And what you do is, again, you find the apical vertebra, or the vertebra which is very laterally placed on the curve. So if that's the whole curve, the one that's very laterally placed is the apical vertebra. You look at the 2 ribs on either side of it, and you measure the angle between the perpendicular to the apical vertebra and the 2 ribs. And essentially what you do is you subtract the concave rib angle from the convex rib angle, and the difference, if it's more than 20 degrees, then that tells you that, again, the progression is high. So the 3 things we measure are the Cobb angle, if it's more than 20, the RVAD, or the rib vertebral angle difference, if it's more than 20, and if the child has a phase 2 rib. All of these are indicators that this scoliosis is quite likely to progress. Those that don't have these 3 usually means that this curve at presentation is quite likely to resolve spontaneously without any treatment. So I don't need to put the child in a brace or a cast. I can just observe and see what happens, because most of them resolve. Congenital scoliosis. Somehow we see quite a lot of this here in the UAE. I've not seen as many congenital scoliosis in the UK as I have seen in the UAE in 6 months. There's a significant number. This can cause scoliosis or kyphosis depending on where the hemivertebra is or where the block is. If you have a block or a hemivertebra anterior in the spine, then the posterior spine grows and results in a kyphosis. If you have it on one side or the other, then it creates a scoliosis. Check whether the patient has any fused ribs on either side, usually on the concavity of the curve, because this is associated with a high risk of thoracic insufficiency. On your MRI scan, particularly check if you have any abnormal kidneys or an absent kidneys, because development of the spine usually happens at the same time as renal development and cardiac development during the embryonic time, usually in the first 4 to 6 weeks. so they can coexist together. And quite often they produce the same syndrome. So Vectral syndrome or Klippel-Feil, all of these can have anomalies within the kidneys and the heart as well. Check for spinal dysraphism. You can see these on the X-ray, or you can see these on the MRI scan, sometimes on the CT scan as well. Okay, particularly if you have a bony diastema or if you've got a significant bony defect. On X-ray, when you see an X-ray with a child with congenital anomaly, it's much easier for me to get an approval for an MRI scan from the insurance company if it is actually recommended by a radiologist. Congenital anomalies have a high risk of being associated with spinal dysraphism. I need to exclude these because spinal dysraphism can actually result in progression of the curve, and it may need neurosurgical treatment. This image on the right you see in green is actually the different types of congenital scoliosis, and I'm just going to go through it very briefly just so that you're aware. Quite often, most children have an isolated hemivertebra here or there, but they can coexist. It is important to try and establish whether this is a fully segmented, i.e. there's a disc on either side of the hemivertebra. That's important because the child usually grows from the ring apophysis, and that means there's a ring apophysis on either side, which also means that this curve is likely to progress, as opposed to an incarcerated, or which is a semi-segmented, where there's a disc only on one side, which means they can progress, but not as much because there's no growth plate in that area. Okay, and similarly, if you have a situation where you have a hemivertebra on one side, which is fully segmented, and a bar on the opposite side, that type of curve is the one that's most likely to progress. Okay, so it's either because of failure of formation, so you get a hemivertebra, failure of segmentation, so you get a bar, or you get a mixed picture. Neuromuscular scoliosis, you can guess from the X-ray whether the child has neuromuscular scoliosis or not. Usually they're very large C-shaped curves. They don't look like an S, they look like a big C. You've got usually they have a significant pelvic obliquity and shoulder obliquity. They have costopelvic impingement where the ribs actually hit the pelvis and cause a significant amount of pain. Often what you will see is a situation where you have a trachea, or you may find a peg tube, you may find the VP shunt, you may find the VNS here, a vagal nerve stimulator for the seizures. So all of these are usually signs that the child has a neuromuscular condition. Not only do they have a scoliosis, quite often, okay, they also have a kyphosis. Now, this is very different from the very common condition of adult idiopathic scoliosis, adolescent idiopathic scoliosis, where they don't have a kyphosis. In this condition, they tend to have a kyphosis. This is one of the small number of scoliosis where we actually do have a kyphosis. Okay, on MRI scan, we need to ensure that we mention the negatives. These kids can have a hydrocephalus, so if we do have an MRI scan of the head, we need to mention it, or I would request an MRI scan to exclude it prior to any surgery. Again, syrinx, tethers, low-lying conus, and other spinal dysraphisms need to be mentioned. I accept they might not be there, but mentioning a scoliosis, but not mentioning the lack of spinal dysraphism becomes very difficult. The most common type, and the type that you see almost probably on a daily basis for most people, certainly in the UAE, it's a very common condition, adolescent idiopathic scoliosis. Okay, essentially, it happens in adolescence. It's idiopathic. We don't know what causes it. There's many various reasons for it, including genetic factors. Okay, it usually affects females, and it's usually a right-sided thoracic curve. That's what you see. If it's a left-sided thoracic curve in a female, in a male, you would start to get a little bit concerned, and at that point in time, I will do an MRI scan, even if the curve is small. There could be an intraspinal pathology that's actually driving the curve. Okay, like I said, this is almost always a lordoscoliosis. It's not a kyphoscoliosis. The kyphus comes from the actual rib hump because of rotation. They can have shoulder imbalance, like you see here. The right shoulder is higher than the left. Okay. Usually pelvic tilt is not a feature in these kids. If there is pelvic tilt on standing, then that's usually related to a leg length discrepancy. And when we do take the x-rays, and if they do have a leg length discrepancy, then we either put a block underneath the leg to ensure the pelvis is level, or what we do is we get the patient to sit down and have the x-ray sat down so that the pelvis becomes level. So this is something that I have sorted with our radiographer here at the Paley Clinic, whereby we standardized the x-rays for scoliosis. Again, MRI scan. If I am to operate on these patients, they have to have an MRI scan. Trying to explain to the insurance company that I cannot straighten somebody's spine without excluding a tether is very difficult. But if I lengthen this child will be lengthened by nearly 2 inches when we do the surgery. Then what happens is you're actually stretching the cord. If the cord is tethered at the top because of a Chiari, or at the bottom because of a tether, or even in the middle because of a diastem, then it becomes a problem and we can get paralysis during the surgery. So this is why all these negatives need to be mentioned on the MRI scan. Radiographs, what do we look like on what do we look for on a scoliosis film? This is something that I've realized that many people maybe don't do all these measurements. I think the most important thing I need to establish is they have to be done in the upright position, whether they're standing or sitting. If they can't stand because they've got neuromuscular problem, otherwise, then they have to be sat down. It's only in rare cases that I'm happy to accept a lying down film, or if I'm doing it before surgery, because lying down is not with gravity, and therefore the curve actually improves significantly. Okay, that applies to an MRI scan. Therefore, I don't like reports saying there's a curve which is measuring 30 degrees on an MRI scan. The patient is supine. The insurance company will take it. Okay, this is a 30-degree curve. What are you doing? Why are you operating on this child? But in reality, when they stand up, the curve is 50, 60 degrees because it's with gravity. So I prefer if people didn't put numbers on a supine scoliosis, okay, on a supine film, whether it's MRI, CT, or X-ray, okay. The curve, you can say there's a significant scoliosis in the thoracic area or lumbar area, okay, but don't mention a number. Once you mention a number, it will be taken as that's the truth and that's it. I'm trying to convince the insurance company. Otherwise, it's really very, very difficult. From a nomenclature point of view, the thoracic curves are those that where the apex, so it's based on where the apex of the curve is. So this is the apex of the curve, the most lateral area. So for me, this is T12, 11, 10, 11 disc. You can just say apex at 10, 11 disc. Okay. If the apex is between T12 and L1, then that's a thoracolumbar curve, and anything below the L1-2 disc is a lumbar curve. Cobb angles, we measure it from the end vertebra to the end vertebra, which is another reason why we shouldn't do it on an MRI scan, because quite often you miss the end vertebra because of the way the scans have been done. So the end vertebra for this thoracic curve is usually the most tilted vertebra, essentially the one that gives you the biggest angle. So for me, this would be the end vertebra. I would draw a line here. That's the first Cobb. And then it would be this one or that one. They're about the same line, but it's probably going to be this one. For the lumbar curve, which is down here, the apex is L4. Okay. For me, this is less tilted than that one. So I would just go for the most tilted. And then the L5. This one is quite difficult to measure because this L5 usually has an element of rotation. So what I do is I measure from the bottom of the pedicle to the bottom of the pedicle. That would give you a fair idea of where it is, as opposed to measuring or trying to see where the end plate is, because quite often you can't. So bottom of pedicle to bottom of pedicle usually helps a lot. I would look for the Rissa sign, okay, which indicates growth. Rissa essentially is a way to find that skeletal maturity. So they start from the lateral side to the medial side, and they progress gradually over time. We divide them into quarters. For those of you who don't know, I'm sure everybody knows the Rissa scale and the triradiate cartilage. I don't expect people to put what the Rissa score is on the report, but I do expect people to write whether it's open or closed, because that's a huge differentiator from my point of view. Because the Rissa score to some degree sometimes is not very clear. A Rissa 0 can be confused with a Rissa 5. I have the advantage of seeing the child and knowing whether they are premenarchal, postmenarchal, how tall they are, do they show features of puberty or not. So I can tell, but sometimes you can't. And depends on the shape of the pelvis. Sometimes a grade 2 Rissa can look like a grade 5. So for me, a Rissa score, I keep that to myself. But the triradiate cartilage open or close is worthwhile mentioning on the report. Check for congenital anomalies and check for a Bartoletti lesion. I'll show a few examples in a minute of a Bartoletti lesion, how it can impact the scoliosis, and mentioning it becomes important really. Spina bifida occulta. Unusual on the lateral film, they don't always have it, but they can have a pars defect or a listhesis, particularly if they've got a significant kyphosis, for example, like a Schirmer's kyphosis. So this is just a pictorial way of finding where the end vertebra is, okay? And essentially, it's the most tilted vertebra where you find where you put your angle, and then this is another pictorial measure of where you put your end vertebra. So you need to choose the biggest angle at the end of the day, because that's what the scoliosis is. Coronal balance and checking whether they're shifted or not. We use what we call the C7 plumb line. Okay, so you find the center of the C7 vertebra, you draw a vertical line down. You find the CSVL, which is your central central sacral vertical line through the middle of the sacrum. Okay, and the difference between these two usually is your coronal shift to the right or to the left. Okay, that is worth mentioning on an X-ray. Other X-rays I do for surgical planning, you might see them, and the way things work, you probably see them and you wonder what's going on here. These are the various bending films that we do. For every single scoliosis, I do side bending views, and I also do fulcrum bends as well over the apex of the curve that I'm about to correct. This gives me an idea of where I fix my scoliosis, where I stop with my screws and rods, and what sort of correction I should expect, and also whether I need to do any bony cuts or not. Okay, this also tells me how structural the curve is and whether it's a real curve or a compensatory curve. But this is really outside the scope of this talk. But this is just to give you an indication of how we use imaging and how we classify our scoliosis based on the Lenke classification, and how we plan our treatment based on that. I'm happy to answer questions about this later on as well, if people want more information on it. But I don't expect people to go and tell me this is a Lenke 5 curve, on a report. That's not the expectation. So MRI and scoliosis, there's nothing really to say apart from a few things. First of all, please don't just say there's a scoliosis. I'm happy for people to say where it is in the spine, whether it's lumbar or thoracic. But don't mention angles, please, on a supine film or a supine MRI. The sequences we use should be a whole spine, sagittal T1 and T2 with axials, particularly through the lumbar spine, so that we can actually check whether we have any tether and where the conus ends accurately. Also, a T1 axial helps us check whether there's any fatty phylum that may indicate that there may be a tether. Okay, I do use, the only time I use a coronal image, to be honest with you, is for any MRI scan, is for scoliosis, and occasionally for the sacroiliac joint if I'm concerned about it, which is a very rare occurrence, and in some occasions in infective spines I also use it. Clearly, if we have a segment that shows a dilated central canal or a syrinx, or something else really for that reason, then we do need an axial image through that abnormal segment. Again, we talked about mentioning the negatives and essentially mentioning all the negatives, or just say there's no evidence of spinal dysraphism. That's for me is sufficient. I just need to know that's been looked at. Please make recommendations. I don't mind people making recommendations. It helps me a lot when I come to the insurance company. So if you find it's something that requires a CT scan, you can recommend it. If you feel there's any reason for any other sequences, please again let me know. And then similarly, if you feel there's any need for contrast, for example, if there's a syrinx that you feel there may be something above it, or you're not sure, or code signal or otherwise, then recommend contrast, and I'd be happy to repeat the scans. It makes it much easier to communicate with the insurance company with that. If you're concerned about tethering and you're not sure, I don't know whether this is something that we do in Abu Dhabi or in the UAE in general, but there is some evidence to suggest that comparing a prone MRI with a supine MRI can actually gives us an idea if there's a tethered cord or not. In a prone position, the conus can move anteriorly as opposed to the supine position, and that movement in its own right is usually sufficient evidence that there's no tether in the code. So something to look at if this is not something that we do routinely. But we can't be doing a prone and supine MRI on every patient. It's only the ones that we're concerned that there may be a tether or we're not sure about because of, for example, 4 lumbar vertebrae instead of 5 lumbar vertebrae. This can become a bit of a discussion issue. Now, one of my bugbears really is loss of lordosis and muscle spasm on MRI reports. I get a huge number of patients going, I have been told I've got lots of muscle spasm. I need treatment for this because of loss of lordosis in my back, and my curvature in my back is not right. And trying to convince these people otherwise is very difficult. Almost every report I see will have loss of lordosis because of muscle spasm. The same way we don't talk about any deformity in the spine in the supine position, the same thing applies to lordosis. As a matter of fact, lordosis in the spine is a huge topic in spinal surgery and for deformity surgeon, because at the end of the day, we all have different degrees of lordosis, and it's all dependent on what our sacral slope is, what our pelvic incidence is, and our pelvic parameters. And this is not something that we can measure on an MRI scan. We can only measure it on a standing X-ray. So muscle spasm is an active action. You cannot see it on a single image. And to be honest with you, if you have muscle spasm, usually it will be the erector spinae muscle, which would normally increase lordosis because it's at the back, as opposed to reducing it. So this statement on the report creates a huge problem in clinic, and trying to convince patients that the back is okay and the pain is probably just because of some facet joint problems is difficult. Some of them want me to correct their lordosis, which actually for them is completely normal. So please, if we can avoid that, that'd be really lovely. Finally, talking a little bit about metalwork. You will see a lot of spines with a lot of metalwork in it. There's only one purpose. Well, actually, there's more than one purpose nowadays. But 90% of the metalwork we use is for fixation and fusion, or correction of deformity and fusion. Or we do an indirect decompression by putting cages in the spine and fusion. Or we put disc replacements. But even disc replacements need to also fuse to the bone. The edges of the disc replacement need to fuse to the bone. So at the end of the day, the only thing I really need to know when I do a CT scan or an X-ray or otherwise, when there is metalwork, is has that bone fused to the next bone? Has the metalwork become loose? Is the metalwork broken? These are the pieces of information I need to know, which quite often are not present in the report that I send with X-rays, with CT scans. We use different types of metalwork. We use screws, we use rods, we use cages. That's what we call the cages. The things that you see, anything that you see in between the two vertebral bodies is called the cage. I don't know why we call it a cage. It doesn't look anything like a cage, but that's what we call it. It's a cage. Essentially, it's a spacer. Okay, they can be made from titanium. They can be made from plastic, or what we call PEEK, or they can be made from a combination of both, as you see in the top right picture here. This one is fully titanium. This one is titanium mesh, and inside it there's bone graft. And this one, some of it is titanium and some of it is PEEK, okay, or plastic. And you will see some disc replacements. So these are the ones that have a space between them, or they look like they've got a hinge in the middle that allows movement. It is important to check the edges of any disc replacements to see whether it's fused to bone, because the edges need to stick to the bone, but the inside of the mechanism need to be able to move. And we'll go on through some examples in a minute. So what am I looking for on the CT scan? Like we said, I'm looking for fusion. Okay, we check the fusion in both. I check the fusion of the sagittal and the coronal image. I don't see them. I don't really find the axial images to be very helpful. Okay, it is important to look at the facet joints on either side of the facet joint. So you see, this is pretty fused. I'm not convinced that's fully fused. You can support it by looking at your images on the coronal images at the facets at the back, and you look anteriorly through the vertebral bodies to see whether there's any fusion across the bone. What you probably see here is not very much. What you see here is some gas, some gas, some gas. That really doesn't tell me very much as to whether this is fused or not. I need to see bone going across. I don't think this is bone. I think this is part of the cage itself. I don't think there's significant bone across here. But this one I'm not convinced, for example, is fused. There's air. Once there's air, I'm a bit less confused. I'm a bit less certain whether this is fused or not. These ones, to me, look a little bit more fused, and clearly depends on what the facet joints at the back look like. You may find also some bone graft on either side of the transverse process as well. Okay, I do a lot of that. I fuse the transverse processes together, and that's called a posterolateral fusion or a gutter fusion. This is where the lateral gutter is. That's on the lateral side. Okay, so we want to look for any broken or loose metalwork. So what you see is a halo around the screws. Okay, you want to see for a vacuum phenomenon in disc space. So is there gas in the disc space? That usually indicates movement. That means the bone hasn't fused. There's something I call a Lego fusion. So if there's bone going right across from here to there, so something along that lines, okay, I would call that a Lego fusion. It looks like a piece of Lego. And titanium osteointegration. So if this is a titanium cage and you had an MRI, a CT scan, what you see is that the titanium is absolutely stuck to the bone here. Okay, what you might not see is bone going across from one bone to the next, but what you will not see is vacuum. Okay, and you will see that the titanium on either side is completely attached to the bone. That for me is sufficient evidence that there's no movement, and I would say that's titanium osteointegration. So titanium is a metal that attracts bone and it allows osteointegration. That's why we use it a lot. Check for cage subsidence. Now it's difficult for you to tell what cage subsidence look like because you've not put the cage in first time. But in principle, what you want to do is ensure that you can see the side of the end plate properly, okay? And what the cage should be on the end plate, not inside it and not through it. Once it's through it, you can confidently say that's subsidence. So I would say there's an element of subsidence in this lower cage, as opposed to this cage where you can see the end plate quite accurately there. Proximal and distal junctional failure or degeneration. So any segment that has fusion and has been there for a while, what you'll find is the segment above it and the segment below it are the ones that will wear and tear. So when you come to do your report on MRI or CT scan with patients who have had previous surgery, focusing on these segments, the one above and the one below, is usually quite important because these are the ones that usually wear very quickly following surgical intervention. Few examples. This is what I mean by a posterolateral fusion or a bone gutter fusion where the transverse processes have fully fused on either side. Okay, you can see that on the X-ray quite a lot of the time as well. Okay, and this is what I mean by a halo. You're not supposed to have that lytic area around the screw. That usually means that that screw is loose. Okay, and you can probably just pull it out very easily. When a screw is loose, that usually indicates that there's no fusion. You can actually see the joint. Okay, it's not fused, but also what you can see is because there's no fusion, this allows movement, and as time goes on, what you'll find is the screws will become loose or the rod will break. These rods, although they're very big, they're essentially a big paper clip. If you get a paper clip and you keep bending it, eventually it breaks. The same thing applies here. The force that goes through these is probably huge, and then eventually with a lot of movement, if there's no fusion, the metal takes all the force and essentially fails at the end, so you find rod breakages. So this is the talk. I'm just going to go through some examples if time allows, which I think it will.
Somebody was raising the hand.
Oh, is it? We can answer some questions first if people want.
Yes.
Thank you, Dr. AK, for excellent presentation. I believe there are a few hands raised. Dr. Neeta, please go on, Dr. Neeta. You can sit. Dr. Neeta, you have any question? Neeta Serin? Okay. You can share your question on chat box as well if required. So now Dr. AK will be sharing few live cases with us.
If you put just put, for example, Dana. Put Dana first. This one. We'll just give some. We'll just go 3 or 4 so that we can go through.
Screen is not stable.
Mm-hmm.
The screen is not stable. So you have the screen, the left screen.
Yeah.
It's not getting shared.
You need to unshare this.
Yeah, already unshared.
Yeah.
It's closed.
I would then
Share.
It's not getting shared.
It's not. I have the screen here. It's not shared.
Just give us 2 minutes. We are just having few technical issues. We'll just resolve with IT.
What about in the after spinal surgery?
After or before?
Whatever.
Yes. So the evidence, there is evidence for it now. I use SPECT in patients who I am not sure where the pain is exactly coming from, because quite a lot of the patients, and I've actually used in one of these cases, I use SPECT. So if I have a patient who has if I have a patient who has metalwork in the spine, for instance, and the MRI scan and the CT scan are not particularly conclusive, and I want to confirm if the pain generator is exactly coming from a particular area, okay, then I do a SPECT, but only if I think this is a problem that I can treat surgically. So if I think I can treat the problem surgically, but I need confirmation, I use a SPECT. But the SPECT need to show me a specific target, okay, which it does very well. And the few cases I did, usually with junctional problems, with metalwork junctional problems above and below, actually work very, very well. I've used it on a couple of occasions in patients with pain because of infected metalwork.
Yeah,
and that
infection,
also, infection, and that also worked very, because usually it's infection with a low CRP. It's these chronic infections that have been there for a while that shows up, and that actually worked very well. And I also use it occasionally following trauma. So when you have, on occasions, you have patients who have minor trauma, they have small amount of kyphosis, you treat them non-operatively, they're doing fine for a year, 2 years, whatever, and then they come back with a lot of pain. The SPECT CT helps me identify whether the pain generator is because of the kyphosis at the front of the vertebra, or is it at the back, at the facet joint? And that clearly changes my plan. If it's at the front of the vertebra, you need to do anterior surgery.
So another very small question, just clarification. You were talking about Bartoletti. You probably mean Bertolotti. So
Bertoletti, yes.
No, Bertolotti is the where the transition zone is fused. I mean, where you have like lumbosacral
transitional segment. Yes.
So it's a Bertolotti.
Bertolotti. So it's
that's good. That's good. Go ahead to the images. Actually, we see only one window of this image. We see only the one. So this is what we see.
Yeah, because you've got essentially this is two screens, which
Yes.
Right. They're both the same anyway.
So
They're
this
both
is
the same image at the time. Yeah.
So you want to see a
Yes.
preview, right?
Where's the measurement?
I will check.
So,
We see the mouse. We see the mouse.
Yes. Where's the lines? I think. Yes. Okay. I know what to go on. Okay. So this is a. I'm just going to go through how I would look at these images, and I would just. So first of all, I look at the image. Essentially, what we've got here is a thoracolumbar curve. The apex is at the level of T12L1. So this is the apex at that disc. That's the most lateral area. So this is the thoracolumbar curve. Okay. The one important thing that you'd notice is most of them, or it should be, what we do with our protocol now is we try and see both shoulders, okay, because that's important. It gives me the contour of the skin, because at the end of the day, quite a lot of these children come in with the shape. They want something done for the shape, right? So they have a very prominent, she has a very prominent right hip. The left hip is not particularly prominent. She's now probably Visa 4, okay? This is what I look at. Shoulder balance is well maintained, okay? And what I do then is I measure coronal balance. So I measure it from here. I just draw a straight line if I can, okay? And I try and find out how far is the central sacral vertical line away from the C7 vertebra. She does have a little bit of a coronal shift to the left side, but this is very minor. So this is not something I'd be too concerned about, okay? Let's try and delete that.
I will help you. I will.
Okay, delete. Okay, now just with regards to measuring the curvature. So the curvature, is it measured from this one, or that one? Okay, so for me, the most tilted vertebra is this one here, which is the L3 vertebra. What you see here is if you look at the disc space, Okay, this side is narrower than that side. That means that the curve is still continuing. That side now is wider than this side. So this vertebra is no longer part of the curve. So this is one side of the curve. Okay, and the other side of the curve will be right at the top. Okay, you can see that it's either this vertebra or that one. This one here, okay, is already starting to come out of the curve. The curve is on one other side. Okay, so what I would do here is use the biggest one, and I think the biggest one would probably be this one here. Okay, and that measures about 42 or 43 degrees, and that's what I do with these. This helps me quite a lot. If you look at I think shoulder balance, normally I measure from the top of one clavicle to the other one, and then I draw a vertical line just to see the angulation. She does have a small amount of pelvic obliquity. However, I suspect this pelvic obliquity is actually a rotation of the pelvis related to the scoliosis, as opposed to a pelvic obliquity or a real pelvic obliquity.
Can you explain again? You need to know Richter sign, yes, no, or no, nothing in the report.
On the report, I prefer people not to put it on unless they're definitely sure. Now, Visa 0, Visa 5 can be quite difficult if you've not seen the patient in some cases. Okay, if you can see a clear Visa 1, I don't mind you mentioning it, because Visa 1 is quite easy to identify.
0 to 1, yes.
Yeah, 0, 1 is fine. 2 is okay if it's very clear. So in this type of pelvis, you can see 2, 3, 4 all the way around easily. In some pelvises where the iliac wings are a bit closed, okay, you reach to 2 and you cannot tell.
I'm asking because we need to have very clear points after the talk today, how we're going to report all those
X-rays,
scoliosis.
Okay. So the most
nothing. We don't talk about that. That's
don't talk about that. So for me, open closed triradius cartilage, okay, and an accurate measurement of the angle. This is the most important thing.
Can I just know this spine to discuss? We have here this left scoliosis of the thoracolumbar area. So if we measure only that, is that okay? But you want to have the compensatory thoracic right scoliosis as well?
Yes. Yes. I would prefer if you also measure the thoracic compensatory one as well. Okay. I think on our part it will show professionalism from that purpose. Okay. And to be honest with you, in some cases the compensatory curve is as large. So in some cases it is quite a lot. It could be 30, 40, 50 degrees in some cases. So I think we should measure them. I don't want people to start thinking, well, this is the main curve, we'll just measure that one. No, I think we should measure all curves. What I wouldn't do though is go further more and start measuring what we call the proximal thoracic curve from here to there, okay, which usually compensates to allow the shoulder balance. So I don't want that. But if we measure the thoracic and the thoracolumbar or lumbar, these two curves need to be measured, okay. If you're not sure about your measurement, then please let me know. I'm more than happy to speak up to people about it, because the problem with it is the insurance company, if you say it's 35 when it's 45, the insurance company will go
talking about the 20 degrees actually now.
Yes.
So if it is 20 to measure or not to measure? I mean,
no, measure. Even 20 is important, because if it's 20, I can brace it.
Okay, understand.
Yeah.
Clear message.
And they will not insure the brace unless it's more than 20.
Okay. Regarding the measurements, Dr. AK, whether we should be taking these measurements along the end plates or we should be measuring at the level of facet joints?
No, at the end plate. So the measurement should be done at the top end plate of one vertebra and the bottom end plate of the inferior vertebra or end vertebra. So two end vertebrae of the curve, the bottom end plate of the lower end vertebra and the top end plate of the other end vertebra.
Yes,
the top one.
Now you mentioned about the tilted vertebra. What is your criteria for the tilted vertebra? Because what happens, it is like a subjective assessment for tilt as well. No, so is there any criteria you are
No,
following?
There's no criteria. You just look at it. It's a look thing. But this end plate is more tilted than this end plate, is more tilted than this end plate. So this is the most tilted one.
Okay.
Does that make sense? So this is where it's almost, imagine yourself drawing a curve, and this is the perpendicular to it. Yes. So this curve is that big. If I draw a line from here to there, and I draw a line from here to there, okay, this is giving me 40 degrees. If I draw a line from here to there, and I draw a line from here to the same line, is giving me 42 degrees. Or 46 degrees.
46.
Okay, so that measurement error is there, plus or 3 minus. But this is definitely the bigger curve, and that's the curve that we need to utilize. Not that's because that's what it is, not because I want it to be bigger, but that's the actual curve. So we just need to make sure that we pick up the end vertebra very accurately. But we can't measure it is from this part. And the other thing you see is on an MRI scan, and you have an MRI scan with that. What they do is the MRI scan probably stops here. So people measure on the MRI scan from here to there. Okay, you end up with a small curve when you've actually left it. You don't have the rest of it.
Yeah.
Okay. And the patient is supine.
Yeah.
And
Anybody from the
how can I bring the
audience?
Depending from
Anybody is having any question? Yes, Dr. Diana, please go on.
Hi, Dr. AK. Excellent presentation. Sometimes it's very good to know what the clinicians expect out of a radiology report, and hearing it right from you is excellent. So you say that Cobb's angle less than 10 should not be mentioned in the report at all.
Say that again.
If the scoliosis has a Cobb's angle of less than 10 degrees, you don't mention it in the report at all.
No, you can just say there's a mild curvature of the spine, which is less than 10 degrees. That's it. I don't mind you writing that. If it's less than 10 degrees, just write there's a curvature of the spine that's less than 20 degrees. End of. Well, I wouldn't mention numbers.
Yeah, perfect. And is there a way you can differentiate pseudoscoliosis from a true scoliosis? Sometimes a lot of trauma x-rays I have seen. I mean, probably, I don't know, it's post-traumatic spasm or something. I mean, is there a way, or you just ask for a repeat and follow-up x-ray?
Okay, good question. So with trauma, I've come from a major trauma center. I have never seen trauma cause scoliosis, okay, or any curvature of the spine. But what I have seen, and it is a very well described, and I've seen a lot of it actually, is a disc list. So people with back pain who have a disc prolapse that have scoliosis, okay, or it's been reported as scoliosis. The way I differentiate is by history, actually, not by the imaging. The imaging, first of all, if you have a disc list, usually the imaging will show significant coronal change. So what you'll see is the head pointing somewhere here. They have a significant coronal change, because the reason this child has her head over the pelvis is because this has happened over a long period of time, and the head has had time, the spine has had time to compensate. In patients who have acute disc problems, what happens is if he had a disc here, the patient, he will acutely move from here to there. He does not have time to compensate. Neither does he have the 3D or the 3-dimensional deformity. So you will not see a significant amount of rotation like you'd see here. So here what you have is, this is the pedicle. The other pedicle is on the other side. You can't see it, as opposed to, for example, seeing two pedicles here, this one and that one. Here at the apex is very rotated. You can only see one pedicle face on. So three things that you can tell: no rotation, significant coronal change, and also from what the surgeon writes to you on the request form. If they say acute back pain, right-sided sciatica, and you do an X-ray and you have a scoliosis, that's probably a sciatic list. Okay. Sciatica does not happen acute. It's not. I don't call it. Scoliosis is not an acute condition. You never see acute scoliosis except for major trauma, where a fracture results in a scoliosis. But you don't see them. I have not seen them with back pain because of trauma. I've seen them because of a disc list. So the patient avoids the disc area to avoid severe sciatica.
Thank you, Dr. AK. I believe Dr. Rajesh is also having one question. Dr. Rajesh, please.
It was an excellent presentation, doctor, and definitely it adds to what we do in our routine day-to-day practice.
Dr. Rajesh, can you just come near to your mic?
Speak up, please, if you don't mind. Thank you.
Audible?
Speak up a little bit if you don't mind.
You're audible? Am I audible?
You are audible, but your voice is a little bit low.
You're very far.
Volume.
Now
okay, try again. Okay, that's fine. Keep going.
In regards to the loss of lordosis, what you mentioned about the spasm. So recently I got a message from the insurance department. Yeah, can you mention this point of loss of lordosis in your impression as well? So as a practice, we do mention about the straightening, or we call it as loss of lordosis, cervical or lumbar. That's a routine what we do day to day in our spine cases. So this was the message given that if you add this line to the impression, uh, it will have some different impact on if we have approval for surgery. So I'm not sure. I'm not like they have not given me any paper or any codes or anything which will have impact. But this was just the message. Just wanted to confirm that. Will it have impact? Should we do because we keep doing the practice and there are some certain terminologies. As you mentioned, don't mention about the number regarding that.
So you've been told that the insurance company wants you to put this on because it will help with approval for surgery.
Yeah. That's it will have some impact on the coding. Like if, okay, the patient has got a big disc and will go for a surgery. If we put that line in addition to our disc, it will have a bigger impact. Means they can claim higher. I'm not sure about that. Just wanted to check out. Is that
Okay.
really that way? Because it may look
that's-
that you will see these lines.
Okay, that's an interesting concept.
I'm not sure.
I'm speechless.
Yeah, I'm as well. Like, so you might see these lines coming up because this message I got, nobody came to me directly.
So this becomes an issue because, and this is what I've discovered over the last 6 months, is unfortunately we are to some degree guided by the robot that is sitting at the desk in the insurance company. But the reality is, it does create some problems in the clinics for the patients that don't need surgery, and the vast majority of them don't. Now, clearly, if you find significant pathology, okay, let's try and sort this out. So, if you find significant pathology, so if you find facet joint arthritis, or please mention that because sometimes it's not being mentioned, okay. Or you find a big disc prolapse or significant foraminal narrowing or degeneration or something like that, then I don't mind it being mentioned if the patient is a potential surgical candidate. Quite often what I find is the scans are not far off normal, if not completely normal, and that phrase has been put there. And then trying to get these patients out of clinic and explain to them that they're actually normal is very difficult. Does that make sense? Is that a good compromise?
Yeah, that makes sense. Yeah, definitely. That makes sense. Because sometimes we will be trying to search for the reason for the pain, like, for example, facetal arthritis. That also has got some impact, like, okay, this is an abnormal case, and we definitely try to give the maximum findings, whatever we see. And as a clinician, you will be matching whether these findings are clinically relevant to the symptoms what patient is presenting, or may not be really relevant. But as a radiologist, we will be mentioning everything, right from straightening to whatever minimal stress or minimal changes, tiny gang, like synovial cyst, everything will be mentioning. Even a dot will mention. But as a clinician,
I need to reassure you. I need to reassure you that my clinical examination is completely irrelevant to the insurance company. So when one example comes to mind, I had a patient who had an L23 disc degeneration, significant degeneration, to be fair to her. But she came in with very low back pain, and her pain was very localized to the L5S1 facet. So the L23 degeneration was causing kyphosis, but she had no pain there. And what she was doing is to compensate for the kyphosis, she was bending her back backwards more at the level of the L5S1 facet to compensate for the kyphosis, and that was causing pain. When I tried to explain to the insurance company that I want to inject the L5S1 because that's where the pain is coming from clinically, they said no. The MRI scan and the CT scan and the X-ray show that the degeneration of L23, you can inject that if you want. I said, but that's not where the problem is coming from. They say you can't do experimental injections. So what you write is actually way more important than what I think. That's why the reports are really, really important.
Yeah, absolutely, Dr. AK. Any other case you wanted to share with us? We can extend. We can extend.
I just need to just put me the case for the. I'll show you which case. Yes. We discussed scoliosis a little bit. I want to put one adult metalwork failure case.
Yes.
If we put
Can you see our screen?
Yes, we see the right half. We see the right. Yes. No, yes. Now we see only the conventional AP.
Yes.
X-ray,
Yes. That's what.
So this is a gentleman that came to me probably about 2-3 months ago now, and this X-ray tells a whole story really. These is half peak, half titanium cages that you see in the vertebral body. When you see one of these stuck on one side, you can tell very quickly that this has not been done very well. This is in the foramen. If you look at the lateral, you can see the cage is actually digging into the bone. This is what I mean by subsidence. This is also subsided. What you expect to see is the cage sitting nicely on the vertebral body or the end plate. This is subsided, but it's not causing pressure on the nerves in the foramen. This is actually subsided and it's come out and it's in the foramen. Okay. It actually looks very nice, but if you look furthermore, there's a good indication here. This halo that you see around the screw, that tells you that there has been movement in that area. Okay, so it's one of two things: either this is infection, okay, or this is loosening of the metalwork. If you look very closely as well, what you'll see is this rod breakage. Okay, the rod is broken here. Okay, that again indicates that there's a pseudoarthrosis or there's lack of fusion at this segment. So these are things you can pick up from the X-ray. Do you have a CT? This is CT. The other thing that you don't see here is also you don't see any fusion on the side of the bones. So where we said that you can have a fusion at the lateral gutters, you can clearly see that there's no fusion in the lateral gutters. Yeah. So
not sorry.
Is it CT now? Sorry.
Again, not getting shared. It's not coming.
There's a lot of good stuff here. Exactly. This is where we need to engage. So that's what I'm saying. Either
construction.
Sorry, guys, it's just a little bit of a technical issue. So just going through the scan again, what you can see very quickly is this significant halo around the sacral screws. That would indicate that there's movement. You can see that there's gas in the disc again. That indicates there's movement. You can see that the cage is
We call that vacuum.
Vacuum
because
phenomenon.
gas is very bad
backside, yes.
It's
Yeah,
protection,
vacuum.
So we call that vacuum.
Vacuum, yeah.
Nothing. No, it's nothing there.
Some of it you need to be careful about because some of it may not be vacuum. Some of it may be just artifact from the metalwork as well.
Yeah.
But again, you can almost see the fracture here of the metal. Probably better seen on the X-ray. But these are all signs of failure. You go on the sides of the CT, you can see there's absolutely no bone on either side. You look at the facets. The facets. How do I find if you look at the facets on the side views, okay, the facets are completely pristine. So there's no fusion attempted in this. Okay, you can see the joint very clearly on both sides. And what that means really is that this is going to fail eventually. Okay, unfortunately, and you can see the loosening here. So eventually, what I did was I had to revise this gentleman, and we had to put a new cage, take that cage out of the foramen and put a new one in. And this is the difference between having a cage that's not subsided versus one that has subsided. So you can see the end plates very clearly. You can see the difference between this end plate here, which is subsided, the cage in it, and this one that hasn't. So these are small things that you can pick up. As a matter of fact, I could not. It was so loose on this side, I could not put a screw in the sacrum on this side because it was too loose. So we have to go into the pelvis for that. But this is a picture of what lack of fusion looks like, and this is what I need reported on these images. Is there's evidence of no fusion at the L4-5 segment, or there's no fusion at the L3-4 segment, or this failure of this and the subsidence of that. I think that is worth mentioning, and I don't mind it, even if it's my case. I don't mind you saying that because it doesn't always mean that's a bad thing. It has to do with the quality of the bone and various other things. This is another adult case. Have we got? Oh, no X-rays, just MRI.
MRI.
Okay, we'll look at the coronal image first. Can you see the coronal image?
Yes.
Okay, you immediately can see there's metalwork in here. Okay, at the L4-5 segment, you have a curvature of the spine, which is concave on this left side. And what you would expect at this point in time when you have a tilted vertebra here, usually at this age group, because this guy's in his 60s, I think, is you'd expect him to have pain in the concave area. So not pain, but leg pain. So sciatica comes in the concave area. So for me, when you look at these images, the immediate thing I would go to is straight away go to the sagittal image, okay, and go onto the foramen and immediately just look at the foramens on the right and the left, and what you see is a significant difference over where the concavity of the curve is. So what this gentleman has is essentially a junctional problem. So he's got metalwork and an attempted fusion. I think it's not fully fused, but he's got an attempted fusion with severe foraminal narrowing on the left side at the proximal level. To be fair, he also has some foraminal narrowing at the left side and the lower level, but probably not as bad. This on the report would be mentioned as foraminal narrowing. For me, if there's fat around the nerve, I'm not too concerned about it. Similarly, this is quite tight. I would say that's tight, but he actually had no pain there. Okay, and what you can see, even this for me. Okay, so there is some fat around the nerve. The nerve is round, so for me, it's a narrowed foramen certainly, but certainly the nerve is not compressed. And you can maybe I have the advantage of seeing patients clinically, and I seem to be able to almost tell how much pressure you need before you can get pain in that nerve root. So this patient, oh, we don't have a CT or an X-ray. What you see is the vertebra at L4-5 is not fully fused. But then again, it's very difficult to remove the cage that they have put in. so unfortunately, I can't show you the CT, but principally what we did, okay, this is the previous X-ray. No. Okay, so this is the previous X-ray. And what you see is there an anterior listhesis at L5S1, okay, here, okay. L45 is relatively flat, okay, and L34 with the AP that we had before, that you can tell that there's a tilt at the segment. So this gentleman has a degenerative scoliosis. Okay, you can see he's had 2 ACDFs here in the past. He's got degenerative scoliosis. You can see the tilt of the L3 on L4. That's causing phenomena now on the left side. Okay, and the similar picture at the L2-3 level, but that's not causing him symptoms. Now we can sit here and measure the angle, but to be honest with you, part of the they always ask for angles for some reason for adult scoliosis, even in the insurance company, and I try to explain to them that it really is not relevant in these patients. It really isn't in an adult. A 20-degree curve in an adult is enough to cause significant problems. So they think that we should measure them all the same as we measure an adolescent curve, which is the curve.
Yeah, that's that.
Oh yes. Okay. So the curve here, I'll show you a few things that I measure here. On the AP, I will measure the curve. So that's measuring around 20 degrees. You might argue to go up there a little bit, but it's not significant. You can manage that, but this is not the issue. With adults, what's more important is what we call the sagittal balance. Okay, so the sagittal balance is something that we measure the spinopelvic parameters. I don't expect you to measure them, because even some spinal surgeons don't utilize these measurements. But this is where these X-rays become useful. Is I measure the what we call the pelvic incidence, okay, by measuring the. I don't know if I can change it. Can I move it? Yes. Okay. So you take perpendicular to the part of the sacrum, okay, and you measure then from here to the center of the femoral heads. Clearly they overlap, so you choose the best area. So he's got something called the pelvic incidence of 54 degrees or 55 degrees, and then I do the same thing between. So this is 5, 4, 3, 2, 1 to his lumbar, measure his lumbar lordosis, and this is 50 degrees. So essentially, we are almost matching this patient. So the pelvic incidence and the lumbar lordosis really need to match. The problem with this patient is because the L4-5 segment is very flat and it's supposed to be more lordotic, he's degenerated at the levels above, and he's trying to open these segments more, which is resulting in foraminal narrowing at the back. So what he needs more lordosis in the lower segments so that he doesn't have more problems in the future. He's clearly very kyphotic here because of previous fractures. I have clinically decided to ignore that. So what I've decided to do is to recreate his lordosis and also decompress the spine at the same time. And we do that with anterior cages. Unfortunately, I don't have lateral pictures, do I? Okay, yes, we do. So I recreate by putting these cages from the front, and it opens the foramen, okay, and it levels the vertebra. So it opens that area so that the nerve, without me having to go from the back of the spine to make space, is now opened at this segment. This is the first stage of the surgery. He's halfway between 2 stages. Okay, so the plan, and it does correct the scoliosis to some degree. So the plan for this guy is for me to fuse from the back, from here to the pelvis, and ignore everything else above it because he doesn't have a problem with it. But ideally what we should have done is really taken all of this down and given him some more curvature here as well. But in the context of a 60-odd-year-old with diabetes and so on and so forth, that's not the right approach. So this is just to show you how we do and how we plan these patients, and the importance of ensuring that we get the right protocols as far as X-rays are concerned.
Thank you, Dr. AK. Excellent cases. I have a few questions. I just wanted to get a few answers from your side. For the pre-operative planning of your spinal surgeries, what all things you expect from radiologist if you are planning for pre-operative fusion?
For fusion surgery.
Fusion surgery.
So all patients that need a fusion must have whole spine X-rays. Okay, I now do whole spine X-rays for all patients because it's important to have a baseline. Okay, if things go wrong in the future, you know what the baseline looked like, so you can recreate it. The second thing I do is they all need MRI scans. So if the patient has a lumbar problem, I just do a lumbar MRI scan, unless on examination they have findings of myelopathy or something, then I do a whole spine. CT scans I only do if I need to. If I need to, especially cervical spine, I always CT them. Sometimes I do a CT angio. You may have seen I've requested for a couple of children, they have craniocervical stenosis, they need craniocervical fixation. These kids need CT scans to check what the bone looks like. Has the bone molded differently? Has it rounded off as it has moved away from space? Okay. What the facet joint looks like now, and an angiogram to check where the vertebral arteries is, because there's a 4 or 5% anomaly rate, particularly in those who have various different syndromes, and therefore operating, you need to know where the vertebral artery when you're operating around that area. So this is the minimum requirement.
Okay. Perfect. Regarding the degenerative spine, Dr. AK, as a radiologist who are more interested to know which degenerative spines you categorize as a non-operative degenerative spine and a spine for the operative procedures.
Okay, so in general, I don't operate on any back pain. Any axial pain, I don't operate on. Operating on axial pain, generally speaking, is unsuccessful. Operating as an open surgery. I do inject facet joints, which are arthritic. I do inject cervical facet joints. The things that need surgery in my book are unstable trauma, cancers, infections, and degenerative problems that are associated with either significant spinal stenosis and claudications and neurological compression that is causing pain. There's a lot of people with disc prolapses, stenosis, pressure on the nerves that have zero symptoms. I don't operate on these patients.
But instability, you operate.
Very good. Instability, I operate. Instability for trauma, I operate. Back pain related instability is a very difficult concept.
Spondylolysis, for instance.
Okay.
Spondylolysis.
Spondylolisthesis. So
spondylolysis.
Yeah, spondylolytic spondylolisthesis I operate on if it's causing pain. Degenerative spondylolisthesis, I am less inclined to open to perform surgery for the sake of back pain only. Okay. This is a situation where I do resort for a SPECT scan occasionally. If the SPECT scan shows that the pain is exactly coming from that degenerative listhesis, then I will operate, although I have to say the results are generally not as good as we think they are.
Perfect. In post-operative spine, Dr. AK, what all common complications you expect and that can be diagnosed on imaging, particularly if it is like a post-op MR imaging you are advising? What all things we should be concentrating upon and what common complications you expect?
Okay, depends on when we do the scan. So if you do the scan in whilst the patient is still an inpatient, it depends where you've operated. If you've operated on the cervical spine or the thoracic spine, what I'm looking for is for cord compression. I'm looking for cord compression. I'm looking for cord signal. Okay. If I'm operating on the lumbar spine, usually what you're looking for is for a CSF leak or a neural injury, which you might not be able to see post-op, to be honest with you, or a recurrent disc, because sometimes you can get recurrent discs, or hematoma. Okay, so hematomas, cord compression in the upper, in the cord level, in the conus level and below, I'm looking for hematomas and CSF leaks.
Okay.
This is acutely following. Within 3 or 4 months, what you're normally looking for is in the lumbar spine, particularly if you're doing a lumbar spine, is recurrent stenosis. And the other thing that you look for is for scar tissue around where your previous decompression was. And this is where I use contrast to try and identify whether we have a recurrent disc or is that all scar tissue.
Okay. Thank you. On vertebral fractures, how you assess vertebral fractures, whether it is a stable or unstable fracture, and
right.
Which fracture we should be getting more concentration?
Which age and which fracture?
Yeah.
Okay, so this is a talk on its own, to be honest with you.
Yes,
but make a talk. Okay, we'll make a brief one. So there is something called the TLIX classification. So TLI. CS, okay, TLIX classification. It is by a guy in the US, and principally, it is very far away from what we used to call the 3-column or 2-column, all 2-column fractures are unstable fractures. Yes, and it depends how you define instability. So, in principle, if you have a posterior ligamentous injury on an MRI scan, so the supraspinous ligament in particular is injured, this is an unstable fracture in my book, full stop. That's it. That needs surgery. Okay. If you have facet joint fractures, okay, that makes it more unstable, particularly if you have a 2-column injury anteriorly. Okay. There are a disc in the cervical spine. A disc prolapse, a disc injury, okay, or disruption of the ALL, which usually is an indication that the disc has been damaged, okay, usually also is an indication that this is an unstable injury in the cervical spine. Okay, so I tend to operate on these. The rest of it really depends on what I call the TLIX classification and the amount of comminution in the bone, and how much stability you've got at the back. So for me, I judge it based on the TLIX score, which is probably another chat, and I've got a lot of images we can go through for trauma. But in principle, unstable means there's a 3-column injury, okay? So anterior, middle, and posterior. Stable is first column is damaged and the rest of it is okay. The stuff in the middle comes with experience, and that's where you'd see me doing standing x-rays or examining the patient, so on and so forth. So this is difficult without full talk here.
Yeah, that's great to know. And very simple question to ask regarding the limbus vertebra.
Right.
Are you giving importance? Being a radiologist, we are reporting whatever limbus vertebra we are seeing, but what clinical implications it carries and how important in your clinical practice?
Yeah, I have to say in the UAE, I've not seen any yet, because usually they're associated with sporty people. So usually it's young patients who are sporty, usually adolescents. From my point of view, they come with back pain. I treat them with physiotherapy and reducing exercise. I don't brace them or anything, and 95% of these settle down spontaneously.
Okay. Thank you so much. Thank you, Dr. AK. Anybody is having any question? For this session, we have Professor Christoforos with us as a moderator.
No, I don't want to say anything because the time is over. But for those that I want to look at that, it calls TLIX, T-L-M.
TLIX.
T-L for thoracolumbar, I for injury, C for classification system. T-L, Thomas, Luther, Irene, Charlie, Sierra. TILICS. Very nice to look at that. They give points that we radiologists need to give, because depending upon our description, the surgeon will decide this is to operate or not. And thank you very much. We had here a ball, discussing and having fun, even the technical problems. And this is not your last time that you're going to be here in radiology.
Inshallah, don't mind.
Okay, thank you very much. Have a nice afternoon, everybody.
Thank you, guys, and thank you for having me.
Dr. AK.
Thank you. See you later.